Fluorescence-guided surgery of the esophagus. What have we learned in 2024? My name is Ori Wiesel. I am the Director of Thoracic and Esophageal Surgery at Safon Medical Center in Israel. I would like to start thanking the organizing committee, Dr. Rosenthal, Dr. Deep, Dr. Lomenzo, and of course the almighty Electra for hosting this lovely symposium this year. Unfortunately, due to the current situation in Israel, I can't leave my country during these days, and I will present virtually the state-of-the-art updates in fluorescence-guided surgery of the esophagus in 2024. I have nothing to disclose. I would like to start with an overview of the last decade of fluorescence-guided surgery of the esophagus, which, as I see it, is the newest tool in surgery since the introduction of robotic-assisted surgery. It all started almost 20 years ago with gastric conduit perfusion assessment when we used angiography. Later on, with the advent of artificial intelligence, AI, introduction, technology, optics, robotics, endosurgery, obviously apps and software, we became to know that precision quantification, specifically with blood flow estimation, speed evaluation, became the mainstay of perfusion. In addition, identification and detection of tumor, lymphatics, and the thoracic ducts became our main major task. This decreased the rate of anastomotic leaks in majority of studies, helped us with decision making at the time of anastomosis, increased the number of lymph nodes harvested, which all translated to increased safety, improved overall outcomes, better and optimal oncological results within foregut surgery. As you can see here, the four pillars of fluorescence-guided surgery esophagus are perfusion assessment, tumor identification, lymph node identification, and thoracic duct identification. All are cited significantly in the past few years. I would like to concentrate today on the assessment of lymphatic system in esophageal surgery using the fluorescence-guided surgery. The first study which I will present showed the importance of fluorescence image-guided mediastinal lymphadenectomy in conventional esophageal surgery. As we know, the adequate lymph node dissection during surgery is very important during staging and obviously affect long-term survival. Mediastinal lymph node dissection is the main stage of esophagectomy, and we know that the lymphatics are adjacent to vital organs, specifically the aorta, trachea, recurrent laryngeal nerve, and the thoracic duct. And they are lying within the deep and within the mediastinum where we don't have adequate exposure and lightening. Hence, the extensive surgical dissection causes trauma and increase the complication profile of the patient. So what the author did, they performed a prospective study in whom they took 59 patients with the injected ICG and compared them to historical control. And they compared outcome intraoperatively and postoperatively and overall outcomes between those two groups of patients. What they found that there was no significant difference in those patients whom they injected ICG versus non-injected ICG in terms of intraoperative blood loss, postoperative hospital stay. They found that there was no reoperation rates increase, no significant difference in anastomotic leak, dysphagia, pneumonia, or other grade 3 complication. They had comparable number of abdominal lymph node dissection and no significant difference in terms of overall metastatic lymph nodes. However, they found that those who were injected ICG had a shorter operative time, lower rate of chylothorax, lower rate of recurrent laryngeal nerve injury, and lower incidence of grade 1 and 2 complications. And all of this with the expense of increased amount of retrieved total number of lymph nodes, increased total negative lymph nodes, and overall higher amount of mediastinal lymph nodes dissected, which improved accuracy of resection survival. So what have we learned? We learned that increased number of total lymph node dissected in the mediastinum, specifically those who lies deep in the mediastinum, the smaller lymph nodes, as were shined by ICG, and specifically by repeated exploration after dissection of the esophagus and repeated back table exploration of this node using ICG, increase the number of retrieved lymph nodes, and this translates to more accurate staging and eventually improved survival. What about complications? The higher definition, the near infrared fluorescence guided surgery enable us to differentiate the lymphatic tissue from delicate nerves, paraesophageal blood vessels, and the adjacent organ, hence increase safety and reduce the post-operative complications. The next topic I would like to present is the selective lymph node surgery in early esophageal surgery. We know that nowadays endoscopic resection is the mainstay of early esophageal cancer surgery, either mucosal or submucosal lesions. We learned to identify that there are two groups of patients. Those with better risk profile, which mean good or moderate histological differentiation, no lymphovascular invasion, shallower or superficial tumors smaller than 500 micrometers of invasion. On the contrary, high-risk features such as poorly differentiated tumors, positive LVIs, and higher than 500 micrometers invasion enable us to differentiate between those two, as we know that the higher, the deeper the tumor invades, and the more aggressive features increase the rate of lymphatics involved and lymph node metastasis. However, there is no consensus yet what is the optimal treatment for these patients. We all know those two groups of patients that regardless to what we are doing preoperatively, those with the same clinical staging as we know, there will be this patient that will have eventually following surgery and preoperative treatment and postoperative treatment, good life without any recurrent metastasis. However, the similar patient with occult metastasis will have full-blown metastasis very early on following surgery. We want to find those patients, even in early esophageal cancer, that have better risk stratification. So what is selective lymph node surgery in early esophageal cancer? I would like you to ignore this handsome surgeon that discusses this technique in the video in the right corner and discuss that the selective lymph node surgery, as others call it sentinel surgery, is already employed in melanoma and breast surgery, as we heard in the previous talk. However, in esophageal surgery, we know that we still haven't identified the sentinel nodes in spite of multiple injection and detection methods. So the sentinel or selective lymph node surgery is a tracer-based selective laparoscopic or thoracoscopic lymph node dissection. It might add an additional tool to identify patients, specifically those high-risk patients in esophageal cancer. And what are those high-risk patients? Either high risk in terms of pathology or high operable risk, such as the elderly and the fragile patients we want to avoid surgery. It will help us as an additional tool for decision making, and maybe down the road, he'll help us to define specifically those patients will need surgical resection for limited. This first paper I want to present is a tailored lymphadenectomy. It's a pilot study from the group of Utrecht University in Netherlands. We all know that low-risk patients, the endoscopic resection is considered curative. However, we didn't identify, or there is no consensus, what about these high-risk patients, as I discussed earlier. Even in those high-risk early versus mucosal versus submucosal dissection, there is variation, such as in the submucosal dissection, in the guidelines, we offer esophagectomy due to increased lymph node metastasis. But we also know that there is rate of patients, that selected patients, that even in the submucosal high-risk patient might benefit from organ preservation. So what the author did, they did a pilot study to evaluate the feasibility and safety of this new treatment strategy of sentinel node navigation surgery. They took high-risk patients, as seen in this table, and injected hybrid tracer, which means both technetium and ICG, endoscopically around the ESD scar the day before surgery. This was followed by preoperative imaging of SPECT to identify the targeted lesions, and selective laparoscopy and thoracoscopy the following days going after this. With the limitation of pilot study, small study, and additional limitation of the author mentioned, they were able to show that the sentinel nodes were detected in all patients, both on the preoperative imaging and surgery. There was overall concordance in terms of imaging preoperatively and intraoperatively, and in intraoperatively, both gamma probe and ICG, they were detecting that all the nodes they were after. There were a total of 4 median lymph nodes for each patient, and as the literature shows, even in these patients, they detected 2, which means 20% metastases in the lymph nodes, as we know from historical controls of 20 to 30% lymphatic spread in high-risk patients. So what the author concluded? That in carefully selected patients, this method will be valuable instrument for limited lymphadenectomy, organ preservation, and personalized treatment on the basis of the lymph node involvement. This paper from our group of friends in Hamburg, Dr. Anne Dupree, Dr. Oliver Mann, and Dr. Isbicki, is a very important and nice paper presenting the fact that they're doing laparoscopic lymph node sampling and identify those high-risk patients whom we should perform esophagectomy following ES. What they did, they took the cohort and divided into 2 cohorts. The first, they did a laparoscopic lymph node sampling, and the second cohort, they did an extended sampling, which means additional gastric artery resection for additional tumor harvesting. Additional lymph node harvesting. They found a 12% increase in those harvested lymph nodes in the extended patients, and they found a significant as well, which show a percentage of positive nodes, which show the validity of their technique, which further on underwent esophagectomy. Else they showed us that we should keep on following those patients, because 2 out of the 17 patients which had negative lymph node during the dissection had progression of disease and underwent esophagectomy later. What have we learned from those two studies? That we have a potent tool in our hand, we just need to make it better, as there will be more and more endoscopic resection for early esophageal cancer due to the AI revolution coupled with better endoscopic and pathological technologies. We'll have more patients coming to us for selective lymph node assessment. This will hold a promise and a powerful tool for potential patient selection for organ preservation, a diagnostic tool to identify lymphatic metastasis during a watchful waiting, for example, after a curative ESG, and will enable us MDT decisions for additional, maybe different type of chemo or radiation therapy or immunotherapy in the follow-up period. The next topic I would like to discuss is the thoracic duct identification using fluorescence-guided surgery. We all know that chylothorax is a very devastating complication and with significant morbidity and mortality. We know from cadavers that there is significant variation in the duct anatomy. We use usually enteral administration of heavy cream or oil during surgery to identify leaks. Nowadays, we can use ICG injected in the small bowel mesentery and the inguinal lymph node. So what have we learned in this sense? We learned that there is an anatomical variation and to identify it during real time. We learned to identify the thoracic duct during real time during surgery, and during real time we learned to identify the leak once it happened. And we learned to identify the ideal time and the source of the origin of it in the injection. We can see in this nice paper the description of that typical anatomy is presented in 50% of patients. However, we can see nicely during real time duplicate ducts, plexiform ducts, branching ducts, all of which can be seen in real time during surgery. We also learned what is the ideal timing, which is between 60 to 120 minutes per injection prior to dissection, which means probably at the induction before the thoracoscopy, which give us a peak time of 90 minutes for detection. We learned that superficial injection in the right inguinal region also enable us not just to identify the nodes and complicate the injection prior to surgery. So the superficial injection, not just the nodal injection in the inguinal region, is a very powerful tool. In terms of leak, we can see the leaking solution, and it enables us during real time a selective NMAS ligation proximal to the leaking area. For those who like a preemptive or prophylactic ligation, this group from Milan compare patients with ICG and without ICG, for all of whom they performed preemptive ligation, and they found that there was less chylothorax, shorter length of stay of those patients where they injected ICG. The author also showed us that selective angiographic perfusion assessment during surgery and lymphographic ICG and administration for the thoracic duct does not interfere with each other during surgery. In my last couple of minutes, I will show the new innovations of our techniques and advance of technology. So as the field of endoscopic surgery and the targeted fluorescence molecular tagged endoscopy is developing, we probably will see more and more injections of tagged molecules prior to endoscopy, which will enable the endoscopist to detect tiny lesions, Barrett esophagus, early lesions, and further enable the pathologist to assess the tumor ex vivo after resection. We know nowadays more and more molecules and peptides that are tagged to fluorescence molecules that detect esophageal cancer. So in addition to pre-op administration, we probably will see more and more tools to find it intraoperative during esophagectomy, and obviously to correlate it postoperatively in the lab or obviously in the pathologist to find the tumor, the lymph nodes with ICG enhancing tools. And last and not least, we are going to see more and more utilization of fluorescence guided surgery of the esophagus in benign esophageal surgery, such as here, a group that injected ICG to an NG tube during Heller myotomy to detect leaks during surgery. We probably are going to see more and more usage of ICG in a benign esophageal surgery, not as in oncological surgery. So with this, I'll conclude. I hope to see you more in 2025 in debates, social media, videos, obviously in ISFGS website. In F, which stands for Foregut Fluorescence Guided Surgery. Thank you very much for your attention. I would like to thank again Raul and the organizing committee for the opportunity to present virtually this year. And I hope to see you all soon in the upcoming meetings and in the next year in the meeting in Miami. Thank you very much and have a wonderful meeting.